Have you ever considered a question that honestly sounds like it belongs in a science fiction novel?
I mean, we look at some pretty wild things on this show, so I'm intrigued.
Right. So, can a skin condition be so intense, like so profoundly destructive, that it literally makes a structural part of the human body just disappear?
Yeah, that sounds completely impossible on its face, right? We tend to think of our anatomy as this permanent fixture. Like, we assume the blueprint we're born with is just the blueprint we keep.
Exactly, barring some kind of external trauma, obviously.
Well, yeah. So the idea that a piece of our anatomy could just vanish from the inside out, it really defies our basic understanding of biology.
But the short, astonishing answer to that question is yes. And today, we are going right into the center of how that incredibly complex vanishing act actually happens.
It is a profound and frankly distressing example of the body fundamentally turning against its own structural integrity.
It really is. We are looking at how structural resorption from an autoimmune condition called lichen sclerosus, or LS for short, can completely obliterate the labia minora. We are talking about a condition that fundamentally alters the physical architecture of the human body.
Which is just wild to think about.
To understand this process, we've pulled together an incredible stack of sources for you. We're drawing on deeply personal patient insights from the Lichen Sclerosis Support Network, or LSSN.
Which is such a vital resource, by the way.
Oh, absolutely. And we're pairing that with rigorous clinical guidelines from the British Association of Dermatologists, the Mayo Clinic, and several heavily researched medical journals that focus on dermatology and gynecology.
So we have a really solid mix of the clinical data and the actual lived experiences.
Right. Our mission for this deep dive is to explore exactly how this destruction occurs at a cellular level, shine a light on the hidden, often silent world of LS, and look at how science and medicine are fighting back against this architectural erasure.
It's a heavy topic, but an incredibly important one.
Okay, let's unpack this, because the concept of architectural changes is usually something we associate with renovating old buildings, not diagnosing a human body.
What's fascinating here is that the medical community intentionally borrows that word architecture to convey the sheer scale of what is actually happening to the patient.
Wow, so they use it deliberately.
Exactly. When clinicians talk about vulvar architecture, they're talking about the highly complex structures of the visible external genitals. So this includes the mons pubis, the clitoral hood, the glans clitoris, and the labia majora and minora.
Right, so we're dealing with highly specialized tissue here, designed for very specific mechanical and sensory functions.
Yes, and looking at the clinical data, there's a really fascinating boundary line drawn by this disease. Assuming you are familiar with the anatomy here, you know there is a distinct transition zone between the external vulva and the internal vaginal canal.
Yeah, and what blew my mind in the journals is how LS respects that border. It aggressively obliterates the external architecture, but it almost never crosses over to involve the vaginal mucosa on the inside.
Right, that strict anatomical boundary is one of the hallmarks of the condition.
Yeah.
It specifically targets the keratinized and modified mucous membranes of the vulva and pretty much stops there.
So how does it actually start? What is the mechanism?
Well, the mechanism of action involves chronic, severe, basically unrelenting inflammation within those specific skin layers. And when that inflammation is left unchecked by medical intervention, the disease progresses through highly predictable stages.
Like a domino effect.
Exactly.
Right.
Early on, a patient might just notice that the skin of the labia minora feels tacky, almost like it has developed this unnatural adhesive quality.
The sources referred to that tackiness leading to a stage called fusing, right?
Yes, fusing.
And fusing is when the labia minora literally begins to stick to the labia majora. But visualizing this from the medical journals, we really need to have a critical distinction between fusing and what comes next.
Yeah, because they are not the same thing at all.
Right. When tissue is merely fused, you can still clearly see two distinct anatomical parts. They are stuck together, but their individual identities remain intact.
The clinical literature is very clear on that precursor stage.
Yeah.
But if the inflammatory process continues, that fusing advances into a much more severe phenomenon known as resorption.
And resorption is a completely different ballgame.
It's an entirely different biological event. The tissue isn't just stuck anymore. It is fundamentally remodeling itself.
I was trying to picture this transition for you as a listener, and the best analogy I could come up with is to think about a zipper versus a candle.
Well, that's a good way to look at it.
Right. So fusing is like a metal zipper that gets completely rusted shut. The two sides are absolutely immobilized and stuck together, but you can still look at it and clearly identify the left side of the zipper and the right side of the zipper.
Right, the structures are still there.
But resorption, on the other hand, is like taking two wax candles and holding a high heat flame between them. As they melt together, they merge into one single unified pool of wax. When it cools down, you literally cannot tell they were ever separate entities.
That is a visceral, but yeah, a highly accurate way to conceptualize the cellular process. In complete resorption, the labia minora is basically absorbed into the labia majora.
It's just gone.
Entirely. The structural distinction is entirely erased. If a physician were to examine the area, it would be perfectly flush. The inner lip is simply gone and it's replaced by a smooth plane of tissue.
The reality of living through that is staggering to me. There is a remarkably memorable and frankly heartbreaking anecdote from the LSSN source that brings this into sharp focus.
The blogger, right.
Yeah. There is a blogger who suffered from excruciating, undiagnosed LS for over a decade. She spent years being told it was just recurring yeast infections or irritation.
Which is a classic textbook example of medical gaslighting.
Absolutely. By the time she finally received an accurate diagnosis, her labia minora had completely resorbed. They were just gone. And she channeled that experience into starting a platform and a YouTube channel to spread awareness. And she named it The Lost Labia Chronicles.
Naming it that perfectly encapsulates the physical loss.
Yeah.
And the grief that comes with it. This isn't just a clinical symptom, it is the loss of a part of one's own body.
And it often occurs over years of confusion and misdiagnosis.
Right.
So what does this all mean on a biological level? I'm struggling a bit with the geography of this. If lichen sclerosus is a systemic autoimmune condition, meaning the body's immune system is the culprit, why is the destruction strictly limited to this highly localized region of the vulvar architecture?
The great question. Why doesn't the skin on a patient's arm or leg just melt away in the same fashion? Well, if we connect this to the bigger picture, we see that autoimmune diseases often target highly specific proteins that only exist in certain tissues.
Ah, okay.
Yeah, so in lichen sclerosus, researchers have identified autoantibodies that are specifically targeting a protein called extracellular matrix protein 1, or ECM1.
ECM1, got it.
You can think of the extracellular matrix as the biological mortar that holds the bricks, the skin cells, together.
Okay, so the immune system suddenly decides it just hates the mortar.
Basically, yes.
And when those antibodies attack the ECM1 protein, the mortar crumbles, the scaffolding collapses, and the architecture of the labia physically caves in on itself.
The collapse is exactly what produces the striking visual symptoms cataloged in the dermatological guidelines.
What does that look like clinically?
As the scaffolding is destroyed, the skin loses its foundational support. It thins out dramatically, taking on this crinkled, waxy texture.
The medical literature frequently describes it as looking like cigarette paper, right? Or crumpled cellophane.
Yes, exactly. Furthermore, the pigment is often lost in that area, resulting in the formation of stark ivory-white plaques.
The journals also highlight a very distinct geographical pattern to those plaques. The inflammation doesn't just happen at random spots.
No, it has a very specific shape.
It frequently forms a figure-of-8 pattern that loops entirely around the vulvar structures and then extends down to encircle the anus.
Right, and that figure-of-8 pattern is crucial for diagnosis. But it also brings us to a devastating mechanical problem.
Because the skin is so thin now.
Exactly. Because the scaffolding is gone, that ivory white skin becomes incredibly fragile. It loses all of its natural elasticity and resilience.
Which leads to the itching, I assume.
Intense, intractable itching. But because the tissue is now as delicate as wet tissue paper, the simple act of scratching causes purpura, which is bleeding under the skin, and extremely painful microtears.
Which introduces a genuinely cruel biological trap that the sources discuss. You have a patient dealing with an agonizing itch, but scratching it actually summons more disease to the area.
Yes, the medical term for this is the Koebner phenomenon.
Right, the Koebner phenomenon. How does that actually work?
It's a fascinating and, frankly, frustrating quirk of certain inflammatory skin conditions. The mechanism works like this. When you inflict physical trauma or friction to the skin, like scratching an itch or wearing excessively tight clothing, or even friction from horseback riding.
The body's natural response is to send immune cells to the site to heal the microtrauma, right?
Exactly. But in an autoimmune patient, drawing more immune cells to the area simply fuels the fire.
Wow.
Yeah, the trauma actively triggers the formation of new disease lesions in that exact spot.
It's an agonizing, self-perpetuating cycle. You itch, you scratch, you create a micro tear, the immune system rushes in to fix it, and in doing so, it just destroys even more of that ECM1 scaffolding.
It's a terrible loop to be caught in.
But I want to explore the demographics behind this because looking at the Mayo Clinic data, there's a very specific pattern to who actually gets caught in this cycle.
The bimodal distribution.
Right. The incidence of LS spikes massively in two distinct groups, prepubertal girls and postmenopausal women.
Yes, very specific life stages.
So how much of this autoimmune fire is being fueled by hormones, considering both of those life stages are characterized by a low estrogen environment?
Well, the hormonal component is a massive piece of the puzzle,
Mhm.
while LS is primarily an autoimmune and genetic disease.
Wait, genetic, like it runs in families.
Oh yeah, we know this because it frequently occurs in monozygotic twins and shows strong familial clustering. But the bimodal age distribution you mentioned is no coincidence.
Okay, so where does estrogen come in?
Estrogen plays a vital role in maintaining the thickness, elasticity, and barrier function of genital skin. When estrogen levels naturally drop before puberty or after menopause, that skin barrier naturally thins out.
Ah, I see. So if the skin barrier is already naturally weakened by low estrogen, it might suddenly expose those ECM1 proteins to the immune system.
Exactly, acting as the catalyst for the autoimmune attack.
You combine a genetic vulnerability with a low estrogen environment, add a little bit of friction to trigger the Koebner phenomenon, and the whole architectural collapse is just set in motion.
That convergence of factors creates the absolute perfect storm for this highly destructive inflammatory response.
Right.
And as the LSSN patient narratives powerfully illustrate, the destruction doesn't stop at the loss of the labia minora.
Here's where it gets really interesting and, well, deeply sobering, because we aren't just talking about cosmetic changes to the skin.
Not at all.
The sources emphasize that we are talking about severe life-altering mechanical failures of the human body. When you lose that elasticity and the tissue begins to scar, the functional fallout across the entire pelvic region is just immense.
Let's break down that functional fallout, starting with a condition called clitoral phimosis.
Okay, what is that?
Well, the clitoral hood is designed to act as a protective, retractable sheath, but under the chronic inflammation of LS, that hood scars and eventually fuses together.
Oh, wow.
Yeah, it acts like a rigid cast, completely burying the clitoris underneath a thick, unyielding layer of scar tissue.
And the mechanical problem there goes way beyond just the loss of sensation. Because the anatomy is trapped, the natural bodily secretions and dead skin cells have literally nowhere to go.
Right. They get trapped underneath that fused scar tissue.
Which leads to the formation of smegmatic pseudocysts. And from what I read, these are essentially highly pressurized, incredibly painful pockets of fluid and debris just locked under the skin.
Yes. And the structural collapse also heavily impacts the vaginal opening, creating a whole cascade of intimacy and functional issues.
Even though we established earlier that LS doesn't affect the inside of the vagina, right?
Right, but it utterly destroys the elasticity at the entrance. As the scarring tightens the tissue, it leads to introital stenosis, which is a severe physical narrowing of the vaginal opening.
The sources outline the pure mechanics of why that is so devastating. Think about it for a second. During penetrative intercourse, the tissue needs to be able to stretch and yield.
Naturally, yes.
But when you have introital stenosis, the skin is like taut, rigid parchment paper. It physically cannot stretch.
Which leads to dyspareunia.
Right, which is severe pain during sex. And frequently, it advances to aporeunia, where penetrative sex becomes physically impossible. The inelastic skin simply splits open at the base of the opening, an area called the posterior fourchette, literally every single time pressure is applied.
The trauma of recurrent tearing at the posterior fourchette is profound. And we must also look at the other half of that figure of 8 pattern we discussed earlier.
You mean the perianal region?
Yes. The scarring around the anus destroys the skin's ability to stretch during a bowel movement. This inelasticity leads to painful anal fissures and dyschezia, which is agonizingly painful defecation.
And the pediatric data in the journals brings up a truly tragic consequence of that perianal scarring.
The psychological impact is huge here.
It is. Young girls who develop prepubertal LS often experience such severe pain when going to the bathroom that they develop a psychological terror of the toilet. They consciously hold in their bowel movements just to avoid the tearing.
Which, as you can imagine, leads to chronic severe constipation.
Exactly. The mechanical failure of the skin creates a secondary gastrointestinal crisis.
This raises an important question about the holistic impact of lichen sclerosus. We are looking at a disease that systematically dismantles a person's quality of life.
Yeah, it destroys sexual intimacy, it makes basic bodily functions a source of dread, and it subjects patients to relentless chronic pain.
It touches every part of their day-to-day existence.
Then think about the tragic irony here for a moment. You have a condition causing this catastrophic level of mechanical failure and daily agony, yet it thrives in absolute silence.
Because of the stigma.
Yes. People suffer in the dark for decades, constantly applying over-the-counter yeast infection creams, just assuming they have a recurring infection, or that sex is somehow supposed to hurt as they age.
It's heartbreaking.
They endure this because they are simply too embarrassed to talk to their doctor about their genital architecture.
And that societal stigma surrounding vulvar health actively enables the disease to progress. But breaking that silence is critical not just for quality of life, but for basic survival.
Wait, survival?
Yes, because while the structural symptoms are devastating, the clinical guidelines highlight a much darker, hidden threat lurking within that chronic inflammation.
Okay, we need to be crystal clear on this point from the sources for you listening. Lichen sclerosus is not contagious. It is not an STI.
Correct.
However, if a patient avoids the doctor and leaves this chronic inflammation untreated, the medical data shows they face a 4 to 6.7% lifetime risk of developing squamous cell carcinoma, which is vulvar cancer, directly within those scarred, inflamed areas.
The mechanism behind that cancer risk is tied directly to the inflammation. When the immune system is constantly attacking the tissue, the body is constantly trying to repair it.
Which means the cells are replicating faster.
Exactly. The skin cells are forced into an overdrive state of cellular turnover. And mathematically, the faster and more frequently your cells are forced to divide and replicate, the higher the statistical probability that a copying error will occur in the DNA.
Oh, I see.
Over years of unmanaged inflammation, that DNA damage accumulates, turning a localized autoimmune response into a malignancy.
So the stakes are incredibly high. The architecture is collapsing, the mechanical functions are failing, and there is a looming cancer risk.
It sounds incredibly bleak.
It does. So how does modern medicine halt the disappearance? How do we freeze this disease in its tracks before the labia minora is completely resorbed?
Well, the first truth to accept is that there is currently no cure for lichen sclerosus. It is a lifelong autoimmune condition.
Okay, no cure, but it's manageable.
Highly effectively managed, yes.
Okay.
The tissue destruction can be entirely halted. The absolute gold standard of treatment, backed uniformly by the British Association of Dermatologists, the Mayo Clinic, and every major gynecological consensus, is the use of ultra-potent topical corticosteroids.
The sources consistently point to one specific ointment, right? Clobetasol propionate 0.05%.
Yes, that is the heavy artillery. By applying an ultra-potent steroid directly to the affected tissue, we can forcefully suppress the localized immune cells that are attacking the ECM1 protein.
It just shuts down the inflammation at the source.
Exactly. And if caught early enough, this treatment stops the fusing, halts the progression toward resorption, and pushes the patient into long-term remission.
Which I assume also drops the cancer risk?
Dramatically, it simultaneously plummets their risk of developing squamous cell carcinoma right back down to baseline.
But, the sources reveal this fascinating, almost absurd contradiction regarding this specific treatment.
To the warning label.
Yes. If you are a patient and you pick up your prescription for clobetasol propionate, you open the box and there is a giant bold warning label printed inside that explicitly says, "Do not use on genital skin."
I know it is a massive source of anxiety and confusion for patients who read the insert and immediately think their doctor has made some dangerous mistake.
You literally have dermatologists and gynecologists begging their patients to completely ignore the black box warning printed by the pharmacy. Why is that?
Because normally, putting a steroid that powerful on thin genital skin would cause the skin to dangerously thin out and atrophy.
Right, which sounds bad.
It is bad.
Mm.
But in the case of lichen sclerosus, the skin is not normal. It has become abnormally thickened, hyperkeratinized, and fortified with rigid scar tissue.
So it needs that power.
It absolutely requires that sledgehammer potency just to break through the disease barrier. For this specific condition, ignoring that warning label is the only thing that will save the tissue.
It perfectly illustrates why specialized disease management often contradicts generalized pharmaceutical rules.
Exactly.
And alongside the steroid regimen, the patient advocacy groups, particularly the LSSN, emphasize the necessity of preventative daily routines.
Like emollients.
Right. Using heavy emollients, which are essentially thick, specialized moisturizers, creates a physical barrier over the skin. If the labia minora feels tacky, the emollient physically stops the skin from touching and fusing to the labia majora.
It's a simple mechanical fix, but it's crucial.
Hmm.
And the clinical guidelines also advocate heavily for physical therapy,
Hmm.
which might sound surprising for a skin
I
condition.
was definitely surprised when I read that.
But pelvic floor physical therapists can teach patients specific scar tissue mobilization and stretching techniques. By manually massaging and stretching the tissue, patients can maintain elasticity and prevent that introital stenosis from permanently locking down the vaginal opening.
So it's about maintaining the mechanical viability of the architecture.
Yes.
And there is another vital component to management that the patient networks really bring to the forefront, which is the role of the nervous system. Chronic stress is consistently reported as a massive trigger for LS flare-ups.
The connection between the brain and the vulva might not seem obvious right out of the gate. But when you look at the biology, the nervous system and the immune system are in constant communication.
How does that work in this context?
When you are chronically stressed, your nervous system is locked in a sympathetic fight or flight state. Your body is flooded with cortisol and adrenaline, which actively promotes systemic inflammation and triggers the immune system to become hyperactive.
And that heightened inflammatory state is exactly what a patient with an autoimmune disease needs to avoid, right?
Exactly. This is why interventions targeting the vagus nerve are gaining so much traction in the LS community. The vagus nerve is essentially the master brake pedal for the nervous system.
So by learning to stimulate the vagus nerve through targeted deep breathing protocols, meditation, or specific physical exercises, you can manually shift your body out of fight or flight and into a parasympathetic rest and digest state.
Yes. You calm the nervous system, which acts as a physiological cue to calm the autoimmune response. It's a remarkably holistic approach to a localized problem.
It really is. You attack the localized fire with the steroid, you protect the remaining architecture with emollients and physical therapy, and you manage the systemic triggers by downregulating the nervous system.
That's the ideal management plan.
But let's look at the worst-case scenario. What happens if a patient went undiagnosed for decades, like the blogger from the Lost Labia Chronicles? What if the architecture has already completely collapsed, the clitoris is buried, and the vaginal opening is sealed shut?
When the mechanical failure is absolute and irreversible through medication, surgical options are considered.
What kind of surgeries?
Surgeons can perform a lysis of adhesions, which involves carefully cutting through the rigid scar tissue to unbury the clitoris or separate fused structures.
Okay.
Or they might perform a perineoplasty, which surgically reconstructs and opens a narrowed vaginal entrance to restore the ability to have intercourse.
But the clinical literature draws a very hard line in the sand regarding surgery. Surgery is only utilized to mechanically correct severe architectural distortions.
Right. It does absolutely nothing to cure the underlying autoimmune disease.
That is such a critical caveat. The immune cells attacking the ECM1 protein are still present in the tissue.
Exactly. If a patient undergoes a painful surgery to unbury their clitoris, but they fail to maintain their medical treatment with topical steroids afterward, the inflammation will just immediately return.
The scar tissue will rebuild itself, and the anatomy will become trapped all over again.
Surgery can rebuild the broken structure, but only consistent medical management can treat the active disease.
It is an absolutely incredible journey we've taken through the research today. We've seen how lichen sclerosus operates as this powerful, nearly invisible autoimmune force. I mean, one capable of completely reshaping human anatomy, erasing the labia minora, and functionally shutting down a critical part of the body.
Yet, we have also seen the resilience of the human spirit and the real precision of modern medicine. Through the strategic application of ultrapotent steroids, diligent tissue mobilization, and comprehensive nervous system management, patients do possess the tools to halt this vanishing act and fiercely reclaim their quality of life.
And this information matters to you, the listener, even if you never experience a single symptom of lichen sclerosus in your entire lifetime.
It's a universal lesson, really.
It is. Understanding how the human body can silently turn against its own structural blueprints is a profound reminder of our own vulnerability. It's a call to always listen to what your body is telling you. If something feels mechanically wrong, if there is hidden pain that disrupts your life, you have to speak up.
Absolutely.
Do not ever let societal embarrassment over your own anatomy silence your right to medical care, validation, and answers.
The stigma and the silence surrounding vulvar conditions are often just as destructive to a patient's life as the biological disease itself. Breaking that silence is the first step toward healing.
I want to leave you with a final thought to mull over as we wrap up this deep dive. We started this whole conversation by asking if a skin condition could truly make a structural body part disappear. We know now unequivocally that it can.
We do.
But consider the flip side of that reality. If the human immune system is powerful enough to completely melt away and erase a physical part of our anatomy just by making a microscopic biological mistake with one specific protein, what does that reveal about the sheer magnitude of the delicate, invisible forces required just to maintain our physical form every single day?
It implies that our bodies are not the permanent, static monuments we believe them to be, but rather active, ongoing biological negotiations.
We are literally holding ourselves together, cell by cell, structure by structure, in a quiet, invisible war beneath the skin. Think about that the next time you look in the mirror. You are a masterpiece of biological tension. Until our next deep dive, keep questioning the hidden world inside you.